Allah, they have many questions. I submitted my questions 1 year before. I don't remember my questions. So you are ready once you understand this information, the basics. Inshallah, you will be ready. Don't worry.
So it's يعني like causes, treatment like that.
Yeah, all these possible questions. Okay. طيب. Do you want to hear a joke? Huh? See this comic? Technology reach everywhere now, even pacemaker. Okay, let's resume. Now, let's talk about calcium. Okay, calcium. Calcium, where is calcium? Take calcium, تشرب الحليب, صح? This calcium is in the bones, صح? You know this song? Okay, my daughter singing this song always about calcium. Okay, there is one Arabic song about milk, and for the bones like this. Okay, so the normal level 8.5 to 10.5 function, neuromuscular transmission, and bones and blood clotting. Remember, blood clotting is the calcium is the cofactor in the coagulation cascade. Coagulation cascade, okay? And found mainly in bones and teeth, and can be ionized and non-ionized. That's why doctor asked, send ionized calcium. Send non-ionized calcium. Ionized means the one is with the ion. This one. So positive. So this is the one, right? So this will be ionized. Non-ionized means it's stored in the bone. Okay? So, or شوية when you make this one is still not yet become iron. Regulation, vitamin D allow the bone to take the calcium. So now check, all of you always try to check your vitamin D. This vitamin D deficiency is common because we are not exposed to the sun. And calcitonin will allow the calcium to stay in the bone. So this will maintain calcium in the bone. And this will allow calcium to go in the bone. This can allow calcium to stay in the bone. Okay? So this law means losing calcium from bone. This allow means calcium not going to bone. This one is opposite. This allow to make the calcium go from the bone to the serum. So this parathyroid hormones, okay, will make the calcium move from the bone to the blood. Will make osteoporosis. Okay. For hypocalcemia, symptoms can be decreased cardiac contractility, neuromuscular symptoms, mental changes, fracture. Suddenly the patient walking, simple jump, and you will have fracture. Okay? Trososign and Schiphospheric sign, this is something can be assessed clinically. Like this trososign, they bring BP cuff and they inflate, the patient's hand will start to become like this. This is for hypokalemia. And for Schiphospheric sign, the patient, when you tap on his face, this side will make like this. When you just tap, simple tap, it will have reflex. Okay? This patient with hypo, this is to be positive, this may indicate intervention. Okay? Causes: reduced calcium intake, low parathyroid hormone, because now I have more calcium in the bones, or move from the system, the body, from the blood to the bones, or electrolyte imbalance, in particular phosphorus, magnesium, and albumin. These three, imbalance in them may affect calcium. Okay? Massive blood transfusion, because part of the blood anti-clotting that's used in the blood bags is having calcium. Okay? And alkalosis. Alkalosis in the blood may cause the calcium to move from the blood to the bones, or lost in the urine. So this is the trososign. This will BP cuff and this one with tapping on the face. Interventions: replace and don't make rapid replacement for calcium like all electrolytes. Patient who is taking digoxin should be monitored carefully. New arrhythmia can happen with the calcium. It may cause even sudden arrest. Okay, so patient who is taking digoxin in combination with the calcium, make sure that you are monitoring carefully. Electrolyte deficiency like magnesium and phosphorus, replace. Okay, and vitamin D supplement. Right? Hypercalcemia. Now I have more calcium. Right? Remember the 3 regulation. I have now potassium, vitamin D, calcitonin, and thyroid hormone. So symptoms, again, muscle weakness and pain, diuresis, nausea from GIT symptoms, headache, confusion, arrhythmia. Okay? No need to memorize symptoms because they are similar. Causes: hyperparathyroidism. The parathyroid hormones taking the calcium from the bone to the blood. Bone malignancy in tumor, it will cause the bone to lose the calcium. And drugs like a lot of vitamin D or even thiazide diuretics like metolazone. This will allow the calcium to increase in the serum. How to treat? Give normal saline to dilute and promote excretion. Replace calcitonin to allow the calcium to stay in the bone. And also when you replace, you monitor for fluid overload. Fluid overload. Okay? Let's talk about magnesium. Any question about calcium? Right. Magnesium, normally 1.8 to 2.1. It's good, it's important for enzyme reactions. A lot of enzymes need magnesium, but most notably for cardiac contractility, you will have symptoms, and we will see what symptoms now. For hypomagnesemia, it will be caused by diuresis, decreased GI intake, malnutrition, some nutrients like in nuts and spinach. This will cause the absorption of magnesium to be slow. If someone taking too much, I check for myself, magnesium was low, 1.6. Okay? So you can check for yourself with that according to diet. Some food will prevent the consumption of magnesium. Okay? Even electrolyte imbalance is common in us, but we are not checking. Right? So symptoms will be evident if less than 1. Can cause seizure, confusion, lethargy. Cardiac symptoms like torsade de pointes. Torsade de pointes is VF. The patient will have VF, but it's VTAC, but it's twisted. So there is a twist here and twist here. If you have a thread, right, ribbon, and you twist the ribbon, this is a twist. So torsade de pointes. So this is a twisting of the points. Some people read it torsades de pointes. Actually, it's a French word. So this is how to pronounce it. Okay. So this, when you see this rhythm like that, VTAC, and there is a twist here, and this going upside down again. This is hypomagnesemia. They usually commend an ACLS to give magnesium quickly. Okay. Intervention: give magnesium. Of course, monitor the patient, can be oral also. For hypermagnesemia, can be caused by renal failure. Some medication to treat preeclampsia contain magnesium. So this patient will have hypermagnesemia. Symptoms again, respiratory depression, notably cardiac arrest, and other symptoms. You should also monitor for tender reflex and respiratory status for this patient, because the tender reflex will be slowed down for hypermagnesemia. Anything that contain magnesium, stop it, and normal saline for dilution, and calcium gluconate if the level above 6 milligram. So calcium gluconate now treating 2 things high. What? Potassium and magnesium. Potassium and magnesium. And you can think, oh, I have hypomagnesemia. Oh, maybe I have also hypokalemia. Or you have hypokalemia, you may also have hypomagnesemia. Think both of them sometimes they associate. Okay. So when you have electrolyte, don't send just for potassium, send for other things. Phosphorus. Phosphorus is very important for metabolism. You heard about ATP? ATP. Yes. Who didn't hear? ATP is our body take glucose, make in the blender, then it will make ATP. Give ATP to any cell. This cell will make this ATP to energy and then it will function. So this is the energy unit. So ATP include phosphate. Phospholipids is the cells have phospholipids in the wall. All the cells have phospholipids. So we need phosphorus. We need a lot of phosphorus, okay, in our body. And regulated by calcitonin and parathyroid hormone and vitamin D, like what?
Calcium.
Like calcium. So I have also problem with phosphorus. I may have problem with calcium. Okay. Hypophosphatemia can be caused malabsorption, vitamin D deficiency. Some agent to reduce phosphate like sevelamer. We use it for hyperphosphatemia. If this patient taking sevelamer at high dose, it causes hypophosphatemia. Symptoms, cardiac, neuro, respiratory. Interventions, treat underlying cause. The first thing, diet modification, oral phosphate, IV in severe case, or if the patient cannot take oral phosphate. Oral phosphate. For hyperphosphatemia, the kidney can be the cause, kidney failure, too much phosphate intake, or injury, extracellular shift during injury, so it will move from the cell to the blood, and cellular destruction. So remember, patient with burn again, patient with too much surgery, too much bleeding, this may cause, they may have the electrolyte imbalance. Symptoms, bone and joint pain, muscle cramps, and hypocalcemia associated with hypophosphatemia. All right? Phosphorus binding agents like sevelamer, and also treatment for hypocalcemia. All right? Last electrolyte we'll talk about today is chloride. Chloride. Do we give chloride a lot? No? What about sodium chloride? Where is sodium chloride? Where is sodium chloride? Normal saline. In the food, in the salt that you put in your breakfast. Sodium and chloride, they are coming together. Okay? Because this is a positive, this is a negative, they have one combined called sodium chloride or table salt. The chloride, normal level 95 to 108, part of the hydrochloric acid, which is produced where? Stomach, in the digestion. In the anion gap also, it affects the acid-base balance. So how the causes will affect the chloride? When you lose any fluid that high, rich in chloride, like gastric juice, patient who have NGT drain or too much vomiting, or if the patient, let's say, receiving a lot of mannitol, so this will cause loss of chloride. Chloride, once we learn about anion gap, is cause for acidosis or alkalosis metabolic. So you may have hyperchloremic metabolic alkalosis or hypochloremic metabolic acidosis. Muscle spasm, respiratory depression, dehydration. I point this out because this is a notable one for the chloride. Causes hyperparathyroidism, dehydration, respiratory acidosis, so the body will maintain chloride to allow alkalosis. Because more chloride in the body will cause alkalosis. You will see why. Excessive administration of normal saline because it have the chloride. Okay? So in this case, if the patient is hypotensive, what you will do? You may give something that doesn't have chloride. Okay? So that's why there is alternative fluids. Symptoms also lethargy, disorientation, increased rate and depth of respiration. So hyper and hypochloremia, how to treat them? First, treat the cause. Again, the number 1000 times. Treat metabolic acidosis and metabolic alkalosis and replace the acid-base imbalance. That's why the body will control chloride to compensate for acidosis and alkalosis. If you treat acidosis and alkalosis, the body will have the chloride normal again. So, another fun break. Take a breath. Just relax. We'll talk about the next part is acid base. So, another joke. This patient like variety. He wants like coins. He have hobby to collect all the colors. Okay. Right. This is also a sample of the medical alphabet. It's how physicians learn to write. That's you don't wonder. So this is the A. This is the B. This is the C. This is D. This is E. This is F. Once you learn this one, خلاص. You write the same. Huh? Alhamdulillah. But maybe shut down. So be careful. Take picture. Okay. So acid-base balance and ABGs. Okay. Actually, I am taking part of this lecture because I am covering someone else. So this is supposed to be 2 lectures. This is the second lecture now. So this is your ABG, typical, okay? And this is the things that you concentrate on when you read your ABG. The pH, the BCO2, BO2, and saturation, lactate, mercury. First thing is the pH. pH stands for power of hydrogen. Power of hydrogen. It reflects concentration of hydrogen. Why I am talking about hydrogen? Because in our body we have CO2 caused by metabolism. Our body will take carbohydrate and burn it and use it in energy and output CO2. That's why we take oxygen and exhale CO2. And we have water in our body. Once they dissolve together, they will make acid. If they chemically change, they become bicarb and hydrogen. Bicarb and hydrogen ion. So this hydrogen ion concentration reflect the machine will count how much hydrogen there and estimate the remaining. Okay? So if I have more hydrogen, means I have more what? More base, alkaline. If I have low hydrogen, and this part means low. So, means this one is high, this is acid. So that's why the pH low means acidosis, pH is high, alkalosis. You understand now? So you know. Type. The next thing is PCO2. PCO2, P, what's the small p for? Pressure. Pressure of CO2, not concentration. Not concentration. Okay? So pressure of CO2 in the blood. And once CO2 dissolves with water, it will be carbonic acid. And this CO2 produced by metabolism and removed by our lung. And why I'm talking about pressure? Because the ventilator, or when you breathe, you take air in the alveoli that have low CO2 pressure. and your blood have high CO2 pressure. That's why it will reach the alveoli, it will lose the difference in pressure and maintain the pressure in the blood. So let's say if CO2 pressure 46 and in the alveoli pressure is 40. So it will lose the 6 and it will stay 40. That's why when you put patient on mechanical ventilator, okay, and patient have high CO2, what the change will be done to the settings? Increase?
Alveolation ratio.
Huh? No, increase rate. So the rate, you see this patient is washing CO2. Did you hear this word?
Yeah.
Washing CO2. What is washing? This